We will move on now to the perioperative considerations of the head and throat. First, we'll note that these patients are often in the supine position. Most of the time, the patient will be anesthetized in normal orientation with the head of the bed at the anesthesia machine. Once their airway is secure, the anesthesiologist can inform the team that it is safe to move the bed. At this point, the OR bed with the patient securely attached will be rotated 90 degrees. This allows the surgeon full access to the anatomy as long as the anesthesiologist has secured the patient's airway. The procedure should be able to be completed in this orientation. In the event there is a complication with the airway, the procedure is paused, the airway is secured, and the procedure resumes itself, with any necessary adjustments made in regards to aseptic technique. Once the patient is positioned and oriented in the OR per the surgeon's preference, the patient may or may not be prepped. It will depend on the procedure itself, and that is because procedures inside the nose and mouth are considered clean contaminated, and those structures are not cleansed like the external structures. On external structures, the solution used will depend on the surgeon's preference. In my experience, it's been an equal ratio of betadine paint, Hibiclens, baby shampoo, and SureCleanse. Be sure to adhere to the safety precautions that are established in regards to fire safety and preservation of mucous membranes in the event your surgeon wants to use a solution that contains alcohol, as that is a very dangerous solution in this region of the body. Care must be taken to not allow any prep of any kind to get into the patient's eyes, nor let it pool on the face. Also take care that the prep does not run down the side of the face and into the ear, especially Hibiclens. On procedures that require a prep, usually the entire face is prepped from hairline to clavicle. Next, the patient is draped. Be prepared to always drape the patient, even if there's not a prep. Different facilities may handle this in a different way, but being too prepared is always better than not being prepared enough. In the event there is no prep and they drape out like I'm used to, it's done so to protect the patient from our surgical supplies, to keep the patient clean during the procedure, and to provide the most aseptically prepared field as possible given the area we're working on. You may see a turban drape composed of 2 towels or a towel and a half drape combination that are placed around the head and secured by a sharp towel clip, followed by a simple down sheet that covers the chest and legs. In the event the patient is fully prepped, I would anticipate the same style of draping, only with impervious drapes around the head, or possibly a 4-towel square-off combined with the U-drape around the head. In my experience, when the U-drape was utilized, we did not use the bar sheet because the U wrapped around the sterile field and enclosed it. In the end, refer to your surgeon's preference card to be sure and clarify with your preceptor if needed. Next, I want to tell you a little bit about what you need to know in regards to equipment and supplies in these procedures. Just like I mentioned in your ear video, the microscope may be used during these procedures. The same principles apply here as well. Sometimes new scrubs have a hard time functioning in their role when the microscope is being used because the surgeon literally never moves their head during the case. If you haven't experienced it yet, it's kind of weird to have a surgeon work with you and talk with you but never look at you. But if you understand that if they redirect their attention to anything other than the field that is exposed by the microscope, they're just delaying the procedure and making it more difficult for them to resume the procedure when they try to find their place again. Never, ever bump into the microscope. As you can imagine, jarring the microscope makes the surgical field shake, which startles the surgeon, which could in turn injure the patient. Good rule of thumb, take a deep breath and move methodically and intentionally. The sponges used during nose and mouth surgery are usually small and are attached to a sewn-in string. Do you remember what those ones are called? These sponges are counted at all the prescribed times that we perform our counts, but the strings are not counted as the sponge. I say this because it's not uncommon for the string to become detached from the cottonoid after it's been used. You must retain the sponge. That is what you count. The string was just there to help you retrieve the sponge. Dressings used in the nose will depend on whether surgery was performed externally or internally or both. External procedures will warrant an external splint while internal procedures often are packed with bacteriostatic or Afrin-soaked packing sponges. The process of soaking the packing sponges in Afrin is done by the scrub on the back table. The purpose of this is to control post-operative bleeding and congestion, and when they are removed on post-op day 2 or 3, the patient gets to take that first breath through their nose. Take special note that post-operative dressings are not used in the mouth or throat. Standard dressings can be used on the external portion of the throat, otherwise known as the neck, but not in the throat. During the case, however, it is possible for a surgeon to operate within the mouth and pack the throat with sponges so that irrigation solutions and blood don't run down the esophagus. It is imperative that the scrub tech communicate with the circulator that a throat pack has been placed and when it gets removed. The patient cannot leave the OR with the throat pack in place. The instruments used in these procedures are vast, but don't be dismayed. Your textbook does a fantastic job breaking down the categories of instruments for you by anatomical region, and you received a handout that I created for you with your instrument book to find specific instruments. Your text shows you lots of images beginning on page 700. When I was a student, I found it helpful to highlight an instrument and then color over the instrument with that same color, and then I would use several colors. So when there was a list of a bunch of instruments, at least I could say, oh, the second orange instrument is the da-da-da. When in reality, it was the 8th instrument listed, and that was just too overwhelming for me. Finally, the medications used in ENT can be specific, just like the instruments are. The new drugs to your repertoire include decongestants and cocaine. Decongestants, such as Afrin, are also used on the field to simply decongest the nasal cavities, both during the procedure and postoperatively during the recovery. Decongestants are particularly useful when used to saturate your sponges and then be placed in the nasal canal that is not actively being operated on. Cocaine is a vasoconstrictor, just like epinephrine. Cocaine can come in liquid or powder, and it can be applied directly to the nasal mucosa, either by tapping the powder on or by soaking a sponge in the liquid and laying it on. In my experience, this was performed in the OR pre-op, and the drug was never actually on my field. But if it is, meticulously take care of your meds, because cocaine is a controlled substance, so every bit of it has to be accounted for. Now we're going to move on to anatomy of the neck, and surgery of the neck is usually performed to debulk or remove tumors within that region, and it can also include procedures on the salivary or thyroid glands. The neck is a maze of incredibly important structures, but thankfully they are organized into a variety of triangles. We love triangles, don't we? We've learned so many already, why not add a couple more? The neck has both an anterior and posterior triangle, as shown on your slide, which is separated by the sternocleidomastoid muscle. Whoop, right there. There is also a triangle underneath the chin. There are a couple more triangles under the mandible and along the carotid artery, but for the purposes of this unit, you don't have to know all the intricacies of the human neck. I just really want you to respect the neck and all that it houses, and what a travesty it would be if the patient was inadvertently injured during neck surgery. This slide has areas for you to fill in that pertain to important muscles, blood vessels, and nerves, and what they do. Be aware that you very well may need to access additional resources to complete this information. Take the time to do that. I expect you to fill in those blanks and know them. Two more important structures that reside in the neck are the salivary glands and the thyroid gland. The salivary glands have 3 pairs, and in order of largest to smallest, the largest is the parotid, getting smaller is the submandibular, and the smallest are the sublingual glands. We also have hundreds of minor salivary glands, but these 3 are the main attraction in regards to salivary gland surgery. The purpose of the salivary gland is to produce saliva, which irrigates the mouth and contains enzymes to aid in the breakdown of carbohydrates and protect tooth enamel. Salivary glands are removed usually due to stone formation, chronic infection, and less frequently for the removal of tumors. The thyroid also resides in the neck, and you may see it operated on by surgeons in the ENT specialty or by general surgeons. Either way, it falls under ENT. The picture on your slide shows how the thyroid lies directly over the trachea, and it's separated into two lobes, a right and a left. The thyroid is responsible for secreting hormones like T3 and T4, which regulate metabolism and growth. Your ability to regulate calcium is also controlled by your thyroid, hence so many patients receiving treatment for hyper or hypothyroidism. It's important to note that the thyroid is very vascular and meticulous dissection is required during its removal. The scrub tech should be prepared with many 3/0 and 4/0 silk ties for ligating, unless the physician prefers to use an ultrasonic device such as the harmonic scalpel. Positioning patients for their scheduled procedures requires critical thinking to expose the structures that are to be worked on. Again, typically the patient is supine and their head is positioned appropriately, much like you learned in ear procedures. Patients' necks will be prepped and will extend to the superior region of the mandible and extend down to the appropriate shoulder and onto the clavicle and superior margin of the sternum. The drapes will exclude the face and will vary depending on the specific procedure. Usually, you cannot go wrong with 4 towels or adhesive drapes and a U-drape for the head and neck procedures. You may begin to see the usage of an incise drape like an Ioban in these procedures. You'll really start to see them in our ortho unit. If used, an incise drape is used immediately after the towels, but before the U-drape. Another thing you may have on your preference card is a magnetic towel that lies on the patient's chest and helps prevent instruments from falling off the field. The medications and sponges used in this area of the body are like those we've already been exposed to: local anesthetics and hemostatic agents, as well as laps and Ratex. The instruments on your field will be very similar to those you've used in the abdomen, only a smaller variety, and possibly with very fine tips for dissection. The instruments used for tracheal procedures will differ slightly in that you will see some instruments that work with bone and or cartilage, but you've already seen those in the nasal procedures. Finally, the dressings are simple for most neck procedures, same principles as we've used before. Usually these incisions are closed with a running absorbable stitch like a monocryl or a PDS that is clear, and are dressed with steri-strips, 4x4s, and tape. In the event of a tracheostomy, the trach tube needs to be dressed out similar to that of a JP drain in the abdomen. Provide cushion around the trach tube as well as sponges folded around the tube to collect drainage that are then taped in place. And always send the stylet with the patient to recovery in the event of an airway emergency. That's it for the online lecture videos for the ENT unit. I look forward to reading your 321s. See you soon.